everyone, welcome back to the channel. So today we'll be discussing epidemiology of non-communicable diseases. So we first see the definition of a chronic disease. There are two definitions. First is the 1957 Euro Symposium definition, and the second one is by the Commission on Chronic Illness USA. Next, we see what is the problem exactly, how it differs in developing and developed countries, and how is the situation in India. We also learn about proportional mortality rate. We then see what's the epidemiological transition ratio, which is basically the ratio of disability adjusted life years due to communicable maternal, neonatal, and nutritional diseases by disability adjusted life years due to non-communicable diseases and injuries. We then see the various risk factors for non-communicable diseases such as tobacco usage, insufficient physical activity, alcoholism, unhealthy diet, hypertension, being overweight or obese or both, hypercholesterolemia, cancer associated infections, and environmental risk factors like occupational hazards, pollution, and possession of destructive weapons. So there are various gaps in the natural history of a non-communicable disease. The absence of a known agent, multifactorial causation, a long latent period, and indefinite onset. So this is a short note on prevention. There's general measures and population-wide interventions plus integrated approach and the WHO Global Action Plan for Prevention and Control of NCDs, which was formulated for the era 2013 to 2020 and extended to 2030, wherein the target 3.4 in the agendas for sustainable developmental goals deals with non-communicable diseases. We're now going to deal with our first non-communicable disease, is cardiovascular diseases. The four main cardiovascular diseases relevant today are ischemic heart disease, hypertension, stroke or cerebrovascular disease or accidents, and rheumatic heart disease. So we should know the problem statement, the risk factors, and what is the lag time effect, for which is a very important table. And then the symptoms of heart attack and stroke, and then various interventions to reduce the burden of cardiovascular disease like primary prevention and secondary prevention. The last four surgical interventions that are listed in the textbook count as tertiary prevention. So we first start describing in detail coronary heart disease, also known as CHD. So the various presentations of CHD are angina pectoris, myocardial infarction, arrhythmias, cardiac failure, and sudden death. So how do we measure the burden of disease? We examine the proportional mortality ratio, loss of life expectancy, CHD incident rates, age-specific death rates, prevalence rates, case fatality rates, measurement of risk factor levels, and medical care. So we also see a WHO project to check the epidemicity of CHD, which is abbreviated as MONICA, that is Multinational Monitoring of Trends and Determinants in Cardiovascular Disease. We then see international variations of cardiovascular disease, variations of distribution of cardiovascular disease, and then we see CHD in India. What are the risk factors responsible, which can be classified into modifiable and non-modifiable risk factors. There's an important table for the same. It would be very helpful to refer that. So I've listed it down here. The modifiable risk factors are smoking, hypertension, elevated serum cholesterol, and other risk factors like diabetes, physical activity, hormones, alcohol, OCPs, and other miscellaneous factors like dietary fiber intake, sucrose intake, soft water, and low vital capacity. Non-modifiable risk factors are genetics, type A personality, age, sex, and family history. So the prevention of CHD can be implemented by a population strategy in which you have specific interventions like dietary changes, smoking, blood pressure, and physical activity. There are 5 WHO recommendations regarding dietary changes. Would be very helpful if you read the same. And then coming to primordial prevention, it's a very important concept and very relevant in this area, along with Mr. Fit, multiple risk factor intervention trials. We then move on to the high risk strategy, which involves identification of the risk and specific advice for the same. And of course, secondary prevention, which is early diagnosis and treatment, which involves revascularization procedures for patients with angina pectoris, which is recommended for the following 5 groups of patients. Here, patients with unacceptable symptoms despite medical therapy to its tolerable limits. You have patients with more than 50% left main coronary artery stenosis even without symptoms. Then you have patients with 3 vessel disease and left ventricular dysfunction in which the ejection fraction is less than 50% or there's a history of a previous transmural artifact. Infarct, not artifact. Then you have patients with unstable angina who are on medication or angina precipitated on therapy. And you have post-MI patients with continuing angina or patients with severe angina on non-invasive testing. So the various risk factor intervention trials that are listed below would be very helpful to remember some of these for the competitive exams, like Framingham study of 1951, Stanford 3 community study in 1972, the North Karelia project in 1972, Mr. Fit, Oslo Diet a Smoking Intervention Study 1973, and the Lipid Research Clinic study, and of course other secondary prevention trials. Now we move on to our next CVD, that is hypertension. So it's very important to know the classification of BP measurements. It's asked in and out like literally everywhere. So here's the latest classification according to American Heart Association 2025, which is not the one that's given in PARC. That's why I have attached this here. It's a 2025 table adapted using the 2018 table for reference. So normal BP is less than 120 mm Hg systolic and less than 80 mm Hg diastolic. So we examine the effects of hypertension like organ damage and the various errors that one encounters during BP measurement, which can be categorized into observer errors, instrumental errors, and subject errors. WHO recommends the sitting position over the supine position while checking BP. So classification of hypertension can be primary or secondary based on the etiology. And to know for the magnitude of problems, there's a very important diagram called the rule of halves, which is asked in and out during every COMET exam ever. And then for the prevalence in India, we see the patterns of hypertension by background characteristics like age, sex, race, region, etc., BMI, etc. And then we also learn what is the tracking of blood pressure. So if you catch high pressure early, people who have high BP early in life tend to develop hypertension as they grow older. That's the gist of it. And we also see the various risk factors responsible for hypertension. These are also categorized into modifiable and non-modifiable factors. Under modifiable, we have obesity, salt intake, saturated fat, dietary fiber, alcohol, heart intake, physical inactivity, I should say, environmental stress, socioeconomic status, and other factors like OCPs, noise, vibration, and humidity. Age, sex, genetics, and ethnicity are non-modifiable, of course. Then under prevention, we have primary interventions, which include the population strategy, under which we have nutritional modifications, in which it's recommended to decrease the salt intake to less than 5 grams per day, moderate fat intake, avoid excessive alcohol, and restrict energy intake appropriate to body needs. And also weight reduction and exercise promotion, which go hand in hand, health education and behavioral changes that also go hand in hand, and of course self-care. which includes mental health, and other high risk strategies like tracking. Secondary prevention interventions involve early case detection, treatment, and ensuring patient compliance. Our next disease, our next cardiovascular disease is stroke, or also known as apoplexy. It can be classified into ischemic or hemorrhagic strokes, which can be subclassified into lacunar, carotid, and vertebrobasilar ischemic strokes. And hemorrhagic strokes can be classified into spontaneous intracerebral subarachnoid hemorrhages, rupture of intracranial aneurysms, and arteriovenal malformations, basically rupture of the malformation. So in the problem statement, the key points are the morbidity, mortality, risk factors, transient ischemic attacks, and host factors like age, sex, and personal history. So the presenting factors of stroke and transient ischemic attack are important. And then there's a small note on stroke control strategy, and then we move on to the management of stroke. The management of stroke involves special care for diagnosis in these groups, that is, people who are young, people with altered sensorium and mild to moderate hemiparesis. And then we have uncertain history and other unusual clinical features like gradual progression, unexplained fever, papilledema, etc. So why do we need to do this emergency evaluation or emergent evaluation as it's described in the textbook? We have to distinguish stroke from stroke mimics or other causes of rapid onset neurological dysfunction, which is very important. Then we also need to determine the pathology, whether it's ischemic or hemorrhagic. We need to obtain clues about the most likely etiology and predict the immediate complications and the likelihood of the same, and manage accordingly so that we can minimize the damage due to the same. So on admission to the hospital, there are 6 things to be done. Which is given in the algorithm for stroke management. Now our last CVD given in the textbook, that is rheumatic heart disease. In the problem statements, we need to know about the low risk and moderate or high risk populations. Low risk populations are defined as those that have a rheumatic fever incidence of less than 2 per 100,000 children annually, children defined as aged 5 to 14 years, or an incidence of rheumatic fever less than 100 per 100,000 population of all ages annually. Then we see the epidemiological features like agent factors and host factors. So we need to see the agent and the carriers of rheumatic heart disease, that's convalescent, transient, and chronic. Host factors involve age, the peak incidence is 5 to 14 years of age. The prognosis is worse for females, and the incidence is equal across both genders. And then immunity, socioeconomic status, and high risk groups. Then clinical features range from fever, polyarthritis, carditis, nodules, brain involvement, and skin. So diagnosis is done according to 2015 Jones criteria, in which there are major and minor criteria, and each has separately defined for high risk and low risk populations, along with 2012 AHA echocardiographic criteria to grade ECG to diagnose based on echocardiography. So the first episode, 1 major criteria and 2 minor criteria, or 2 major criteria are sufficient for a diagnosis of a case, and for subsequent episodes you need 2 major criteria or 1 major with 2 minor, or even 3 minor criteria would do. So prevention involves primary prevention, secondary prevention, non-medical measures, and evaluation. Moving on to our next non-communicable disease, that's cancer. We first see the definition of cancer, and then we categorize it into carcinomas, sarcomas, lymphomas, myelomas, and leukemias. We also, of course, mention about primary versus secondary metastasis. And then in the problem statement, the key points to be noted are Worldwide, lung cancer is the most common malignancy. Breast malignancy is most common in females. In males, it's lung, but prostate malignancies come second. In India, oral malignancies, lung, esophagus, colorectal cancer, and gastric malignancies are common in males, the top five. And the top five in females are breast, cervix, uteri, ovarian, oral, and colorectal malignancies. So there's a small note on time trends and cancer patterns. And then the causes, which can be categorized into environmental causes that involve tobacco, alcohol abuse, dietary habits. So smoked fish and excess spices predispose to gastric malignancy. Dietary fiber is linked with intestinal, beef intake with bowel, of course the large intestine, and high fat intake with breast malignancy, plus the cancerous effect of various additives, etc. Occupational exposure, viruses, parasites, notably schistosomiasis, customs, habits, and lifestyles, example is Kangri cancer, and others factors also play a role. There are genetic factors as well. And then we'll then move on to cancer control, in which under primary prevention we have various measures like controlling tobacco and alcohol consumption, personal hygiene, radiation, occupational exposure, immunization, foods, drugs, and cosmetics, reducing air pollution, treatment of precancerous lesions, legislation, and cancer education. Mainly educating people about the danger signals or early warning signs. So the early warning signs of cancer are a lump in the breast, change in wart or mole, persistent change in bowel habits, persistent cough or hoarseness of the voice, excessive or irregular menstruation, blood loss from the natural orifices, swelling or sore that doesn't get better, and unexplained weight loss. Then, coming to secondary prevention, we have cancer registration, in which we have hospital-based registries and population-based registries, and early detection of cases and treatment. So now coming to cancer screening, we see the methods of cancer screening. So why cancer screening in the first place? So we detect pre-malignant lesions, and we should know that most cancers begin as localized lesions, and 75% of cancers occur in accessible body sites. So the methods of screening are mass screening by comprehensive cancer detection examination, mass screening at single sites, and selective screening for cervical cancer, breast cancer, and lung cancer. For cervical cancer, we have pap smear visualization using acetic acid, that's 5% acetic acid, VIA, VIAM, VILI, that's visualization in Lugol's iodine, and HPV and RNA testing, which is recommended by WHO. For breast cancer, we have breast self-examination, palpation, thermography, and mammography. There's a bit of detail explained about mammography, the pros and cons of mammography, and there's a small comparison between mammography and thermography. For lung cancer, we have chest x-ray and sputum cytology. The textbook then goes on to describe the epidemiology of selected cancers, like oral cancer. What are the epidemiological factors? Tobacco, alcohol, precancerous lesions, high-risk groups, and cultural patterns, like chewing betel, quill, bidi, chutta, hookah, pan masala, khaini, and nas. Nas is smoked in Russia. And prevention, we have primary and secondary prevention for the same. Now coming to cervix uteri, we see the natural history of the disease and the causative agent, that is human papillomavirus, serotype 16 and 18 are the most predisposing. And we have risk factors like age, history of genital warts, marital status, early marriage, oral contraceptives, and socio-economic class. Under prevention and control, we of course always primary, secondary, and tertiary prevention. Here there's a small table with various measures and the HPV vaccines. Gardasil 9 and Cervarix are the vaccines used to vaccinate against cervical cancer. So coming to breast cancer, We need to know the symptoms and risk factors, which include age, family history, parity, age at menarche and menopause, hormonal factors like increased estrogen or testosterone, prior breast biopsies, prior breast biopsies, diet, socioeconomic status, and others like radiation and OCPs. Then we move on to the prevention and treatment of the same, plus a small note on WHO Global Breast Cancer Initiative. Coming to lung cancer, we see the magnitude of lung cancer, epidemiological factors like age and sex, and risk factors like smoking and others like air pollution, radioactivity, occupational exposure to carcinogens. And then prevention, primary prevention, we have public information and education, legislative and restrictive measures, smoking cessation activities, and national and international coordination. And of course, secondary involves early diagnosis and treatment, which can be achieved by periodic medical examinations and screening. Then we move on to stomach cancer, wherein the key points are the incidence, H. pylori as a risk factor, the non-specific symptoms of a gastric malignancy, and its poor survival rate. Our next NCD is it's one of the most prevalent nowadays, that is diabetes mellitus. So there's a table showing the classification of diabetes plus a short note on insulin resistance and syndrome X. Then we see the problem statement and the natural history of diabetes, and we see the agent factors like pancreatic disorders, insulin formation defects, B cell destruction, decreased insulin sensitivity, genetic defects, and autoimmunity. With that, we have host factors like age, sex, genetic factors, genetic markers like HLA-B8, B15, DR3, and DR4. HLA-DR3 and HLA-DR4 are the most predisposing to diabetes. That is, defects or mutations in those genes. Immune mechanisms, obesity, and maternal diabetes also. Coming to environmental factors like sedentary lifestyle, dietary fiber, malnutrition, alcohol, viral infections like rubella, mumps, or human Coxsackie virus B4, and chemical agents like alloxan, streptozocin, and Valcor, stress, and other factors. Now, how do we screen for diabetes? Either a urine examination or blood sugar testing, which is recommended by WHO. Coming to prevention and control, we have primary prevention, which we have population strategy or primordial prevention. Actually, guys, in your exam, list primordial prevention separately with respect to primary. It's primordial, primary, secondary, and tertiary. So, yeah. Coming to secondary prevention, we should see the aims of secondary prevention, that is to maintain a reasonable blood glucose level and maintain ideal body weight. Treatment can be via diet alone or diet with oral antidiabetics or diet with insulin. A diabetic must also check is glycosylated hemoglobin at regular 3-monthly intervals, follow self-care instructions, and counsel on home blood glucose monitoring. And of course, you have tertiary prevention in case any other complications arise like diabetic foot ulcers, etc. Now, moving on to our next NCD, that is obesity. We see the prevalence of obesity and its epidemiological determinants like age, sex, genetic factors, physical inactivity, socio-economic status, eating habits, psychosocial factors, familial tendency, endocrine factors, alcohol consumption, education, smoking, ethnicity, and drugs like corticosteroids, OCPs, insulin, and beta blockers, etc. So, males have a higher tendency to be overweight while females have a higher tendency to be obese. And then we also should know the BMI classification of adults. It's very important across many subjects. Then we examine the concept of intra-abdominal or central fat accumulation and increased risk of obesity with the same. Then for the assessment of obesity, we have body composition factors including active mass, fatty mass, extracellular fluid content, and connective tissue. Then the various criteria to assess obesity. So to assess body weight, more than 2 standard deviations from the median weight for height renders you overweight. More than 3 standard deviations renders you obese. Next we have body mass index or BMI, also known as Quetelet's index, which is basically weight in kg by height in meters whole square. Another index called the ponderal index is equal to the weight in kgs by height in meters whole cubed plus the interpretation of the same. For kids, you take the weight in grams, multiply that by 100 and divide it by the length whole cube. Length is in centimeters. The next index is Broca index with double C, that is height in centimeters minus 100, and another index called the corpulence index, which is the actual weight by the desirable weight. It should normally be less than 1.2. Then we see skin fold thickness, which the most common instrument used is a Harpenden skin calipers. For boys, it must be less than 40 mm, and girls, it must be less than 50 mm. What is it? It's the sum of the skin fold thickness at 4 sides: mid triceps, biceps, subscapular, and suprailiac. We also see the waist circumference and waist hip ratio. It's a warning sign if your waist circumference is more than 1 or 2 centimeters for males and more than 88 centimeters for females. The other factors like total body water, total body potassium, total body density, etc. So the hazards of obesity, basically the increased morbidity and mortality. So preventive and control measures include dietary changes, increasing physical activity, and other measures. Moving on to visual impairment and blindness, we first see the criteria for distant vision impairment according to WHO. So mild impairment refers to a visual acuity worse than 6 by 12, moderate is worse than 6 by 18, severe is worse than 6 by 60, and blindness is worse than 3 by 60. Then we also see the definition of near vision impairment, wherein near vision is worse than N6 by M0.8 at 40 centimeter with existing correction. So in the problem statement, the key points are the major causes of moderate to severe vision impairment, like uncorrected refractive errors, which is the most common, 53%. Unoperated cataract, that is the second most common. ARMD, acute retinal age-related macular degeneration, that's 4%. Glaucoma and diabetic retinopathy. So the major causes of blindness are as follows. Unoperated cataracts are the major causes of blindness. Second most common is uncorrected refractive errors, and third most common is glaucoma. Plus we also see the WHO definition of blindness. So the epidemiological determinants are age, sex, malnutrition, occupation, social class, and social factors. So we also see the changing concepts in eye care, like primary eye care, an epidemiological approach, the team concept, and establishment of national programs. Then coming to the prevention of blindness, we see the initial assessment of blindness and the various methods of intervention like primary eye care, secondary care, tertiary eye care, and various specific eye ophthalmology programs like trachoma control, school eye health services, vitamin A prophylaxis, and occupational eye health services. Along with other long-term measures and evaluation, we can help prevent blindness. There's also a small note on the national and international agencies, NPC, BVI, Vision 2020, that's the right to sight, and Global Eye Health Action Plan 2014 to 19. Next up, we have oral diseases, in which, of course, you always have the problem statement. Then risk factors and oral health inequalities in society, like as if there are no other inequalities. Then oral diseases, we have dental caries, tooth decay, and periodontal gum disease, tooth loss, oral cancer, oral manifestations of HIV, orodental trauma, and something called NOMA, which is basically a malnutrition in combination with infection that cause a bunch of necrotizing sequelae seen in the age of 2 to 6 years. And of course, cleft lip and cleft palate, and also prevention of the same. Next, we have accidents and injuries, in which we have measurement of the impact of the disease based on mortality, morbidity, and disability. Problem statement showing that injuries can be unintentional or intentional. Most common unintentional ones are motor vehicle accidents or road traffic accidents, and intentionally most common is self-harm. So the causes of accidental deaths can be unnatural or natural calamities. Under unnatural, RTAs are the most common. So the types of accidents involve road traffic accidents, in which you have the risk factors like speed, drunkenness, lack of helmets, and distracted driving and walking. It's not just this, it's multifactorial, it's complex. And I think there are many events that can, cause an accident. So, and you also have prevention, which involves data collection, safety education, and promotion of safety measures like seat belts, helmets, ensuring children remain seated at all times, among other safety measures. Then, alcohol and other drugs like benzodiazepines, barbiturates, amphetamines, and cannabis must be avoided at all costs if you are planning to drive. And of course, your primary care, eliminating causative factors, enforcement of law, rehabilitation services, and accident research, which is also called as accidentology. Then we have domestic accidents like drowning, burns, falls, poisoning, injuries from sharp instruments, bites, and other animal induced injuries. Each of them have their own risk factors, preventive measures, and other special things that you need to know are first aid measures for burns, what are the do's and don'ts to follow, and management of snake bites at various levels like village level, PHC level, district and specialized hospital level, plus antivenom. So the first antivenom in India, no, the first antivenom in the world was created by Albert Calmette against the Indian cobra. Then we have other accidents like industrial accidents, railway accidents, violence, what are the risk factors for violence, and suicide. So we see the reasons for suicide and various preventive measures, which involve a WHO initiative called Live Life. So L would stand for limiting access to means of suicide. I would stand for interacting with media for responsible reporting of suicides. So F would stand for fostering social emotional life skills in adolescents, which is very important. And E would stand for early identification, assessment, management, and follow up of anyone showing suicidal behavior. So with that, we end this chapter on non-communicable diseases. So thanks for watching. I hope this is helpful. Suggestions most welcome. And hope to see you soon. Thanks for watching once again.